If you've ever looked at an x-ray of a broken bone, you know there is a real comfort in that jagged white line. I mean, it's visible. It's undeniable.
Right. The doctor just points to the screen and says, well, there's the problem.
Exactly. You get a cast, you heal, and you move on.
Yeah.
We expect that kind of precision from medicine. But when you step into the world of pelvic health, suddenly that x-ray machine is completely useless. We're looking at a diagnostic landscape that is, incredibly murky.
Oh, it is the absolute definition of diagnostic muddy waters. And frankly, it's a landscape with a really dark history.
Yeah, totally.
For decades, when patients, primarily women, actually presented with severe, unexplained pelvic discomfort, the lack of an obvious, visible injury led to some incredibly dismissive responses.
Because doctors couldn't see a broken bone or a gaping wound on a scan.
Right. So they defaulted to phrases like, it's all in your head or you just need to relax.
Which has to be the absolute most frustrating thing a person can hear when they are experiencing very real, debilitating pain.
Oh, without a doubt.
But thankfully, the science has evolved. Today, we know this pain isn't some psychological phantom. It is rooted in measurable biological and biomechanical realities. And that is exactly what we are going to explore in today's deep dive.
I'm really looking forward to this one.
Today's mission for us is to solve a very specific clinical puzzle. When you, or maybe someone you know, experiences severe pelvic discomfort, how do clinicians actually figure out what's going wrong?
It's a massive challenge.
Specifically, how do they differentiate between a localized microscopic neuroinflammatory fire, which is sometimes linked to a chronic low-grade HPV infection, and a macroscopic physical shift in the mechanical layout of the tissue?
Yeah, what's fascinating here is that to treat this single area of the body effectively, a clinician essentially has to split their brain in half.
I mean,
Well, in one room, they have to think like a cellular biologist looking through a high-powered microscope. But then in the next room, they have to think like a structural engineer analyzing a collapsing bridge.
Okay, let's unpack this because that is a great image. Let's start with that cellular biologist's point of view. Let's examine the microscopic side of the equation.
Yeah.
What is actually happening when a patient is in excruciating pain, but to the naked eye, the tissue looks completely 100% normal?
To understand that, we really have to look at a condition known as provoked vulvodynia, or PV.
Okay.
For a long time, TB was what we call a diagnosis of exclusion. Doctors only landed on it when they had tested for literally every infection, every disease, and just found nothing.
Right, the classic, we don't know what it is, so it must be this bucket.
Exactly. But recent histological studies, which is really just a fancy way of saying they actually looked at the tissue under a high-powered microscope, have revealed a hidden nightmare happening right beneath the surface.
Oh, wow. What did they find?
Researchers used these specialized staining techniques and found that in women with PV, the density of nerve fibers in the vestibular stroma was 10 times greater than in non-affected women.
Wait, really? 10 times greater? So the body is just rapidly growing new pain receptors where they absolutely shouldn't be.
Spot on. The vestibular stroma is basically the connective tissue just beneath the surface lining of the vaginal opening. In a healthy state, nerves are carefully regulated.
Right.
But in PV, we see this process called neuroproliferation. The body is essentially wiring the tissue with a massive surplus of alarm bells. And the mechanism driving this is what's truly fascinating. It all starts with immune cells called mast cells.
Okay, I've heard of mast cells in relation to allergies, right? Like they release histamine when you get pollen in your nose.
Yes, exactly. They are the body's first responders. But in provoked vulvodynia, these mast cells accumulate in the pelvic tissue and they start discharging an enzyme called heparinase.
Heparinase, okay.
Now, heparinase is highly destructive. Its entire job is to break things down. It starts degrading the connective tissue and something called the epithelial basement membrane.
Which is what exactly?
Think of the basement membrane as a protective floor. It keeps the deeper, highly sensitive tissues separated from the very surface of the skin.
I see. So the mast cells are essentially chewing through the floorboards.
Yes, that's a perfect way to put it. And when that protective barrier is degraded, those proliferating nerve fibers, specifically nociceptors, which are your dedicated pain-sensing nerves, they take advantage of that breached barrier.
They slip right through the cracks.
Right. They penetrate the membrane and grow vertically, getting incredibly close to the mucosal surface.
Man, if I'm visualizing this correctly, it's like a home security system gone completely rogue.
Oh, absolutely.
It's as if the motion sensors inside your house have aggressively multiplied by 10, and then they've migrated to the outside of your windows. So now, something that should be totally harmless, like a falling leaf brushing against the glass, triggers a massive 5-alarm fire.
That is exactly it. And to take your security system analogy a step further, the mast cells are like a faulty siren that won't turn off. They are actively vibrating and damaging the walls of the house while the alarm rings.
Wow.
The medical term for that 5-alarm fire from a falling leaf is allodynia. It's a condition where a normal, non-painful stimulus causes severe burning or raw pain.
So we're talking about the friction of a pair of jeans or a light touch or attempted insertion.
Exactly. Because those nerve endings are so dense and so close to the surface, the brain simply doesn't register it as a touch. It registers it as a massive tissue injury.
And to make matters worse, those mast cells aren't just chewing through the floorboards, right? Looking at our sources, they are also releasing bradykinins.
Yes, the chemical mediators.
Right, those are essentially chemical alarm bells that cause intense localized inflammation. So the tissue is highly sensitive, inflamed, and structurally compromised all at the exact same time.
It is a perfect storm of neuroinflammation.
Okay, but this brings up a massive question for me. We know the nerves are multiplying and migrating. We know the mast cells are causing absolute chaos. But what triggers the mast cells to start this destructive cascade in the first place?
That is the million-dollar question.
Because looking at our sources, there's a lot of discussion about human papillomavirus, or HPV, acting as the spark for this chronic, low-grade inflammation. But honestly, the data looks completely contradictory.
You're not wrong. The scientific community is actively debating the exact role of HPV in this localized neuroinflammatory response, and the data really pulls in two very different directions.
Okay, so let's break that down.
On one side of the debate, you have studies firmly asserting that HPV is a frequent direct cause of vulvodynia.
But how so? Because usually, we associate HPV with cervical changes or warts, not this crazy neuropathic pain.
Right, but these researchers found a strong association between this specific pain profile and conditions like squamous papillomatosis.
And those are tiny, often microscopic wart-like changes in the tissue, right?
Yeah, exactly, driven by high-risk HPV strains. The argument here is that the viral infection causes a chronic, localized immune response. The body knows the virus is there, so it sends in the mast cells to fight it.
Makes sense.
But the virus persists, so the mast cells just stay there, keeping the tissue in a state of constant, low-grade inflammatory warfare. And that eventually degrades that basement membrane and triggers the rogue nerve growth.
Which logically tracks. A chronic infection equals chronic inflammation. Makes perfect biological sense. But then, you turn the page in the research and there's the other side of the coin.
Correct. Another major study took a much more granular approach. They used PCR testing, which is incredibly sensitive at detecting viral DNA.
Okay.
They looked for HPV in patients who had actually undergone surgery to remove that painful vestibular tissue. And then, crucially, they compared those results to healthy controls women with absolutely no pelvic pain.
And the results were wild. I mean, they found HPV in only 21% of the patients with the severe pain syndrome, compared to 36% in the healthy controls.
Yeah, it's quite the twist.
The healthy people actually had a higher rate of the virus. That's mind-blowing.
It really is. And because of that stark contrast, those researchers concluded that the presence of HPV in these pain patients is likely just incidental virus carriage.
Meaning the virus is absolutely there, but its presence is just a total coincidence.
Right. It is not the direct cause and effect of the mast cell cascade and the neuroproliferation.
Which is just, how can a virus cause a 5-alarm inflammatory fire in one person's tissue, but live completely silently in another person's tissue?
Well, what's fascinating here is that it highlights the sheer complexity of the human immune system and how much a person's individual biological baseline matters.
Right.
It suggests there might be other underlying factors, perhaps genetic predispositions or biomechanical realities that dictate whether the body ignores the virus or launches a destructive mast cell attack against it.
Wait, hold on. This sounds like an absolute nightmare for a doctor. If the skin looks completely normal to the naked eye, and the viral data is this conflicting, where you can't just test for HPV and say, I found it, how is a clinician supposed to prove this invisible security system is misfiring?
It's tricky.
Do they have to surgically cut out a piece of tissue for a biopsy every single time someone comes in with pain?
That is the exact dilemma, and the short answer is no, they absolutely do not jump straight to a biopsy.
Thank goodness.
Because before a clinician can assume a patient is suffering from an invisible microscopic nerve fire, they have to rule out what they can actually see and measure. They have to evaluate the macroscopic architecture of the pelvis.
So you have to rule out the structural failure before you assume the electrical failure.
Precisely. We have to take off the cellular biologist hat and put on that structural engineer hat. This brings us to pelvic organ prolapse, or POP.
Right, so what exactly is happening during a prolapse?
Pelvic organ prolapse is the descent of one or more pelvic organs. This can be the bladder, the uterus, the rectum, or even the top of the vagina itself, physically dropping down into or protruding beyond the vaginal canal.
Okay.
Now, for a long time, the medical paradigm viewed this simply as a static structural failure.
So like a broken wooden shelf in a closet. The bracket snaps, the shelf drops, and gravity just takes over.
That was the old way of thinking, yes. But emerging biomechanical evidence has forced a massive paradigm shift. We now understand that we cannot conceptualize POP as a static failure. It is actually a dynamic equilibrium disorder.
Dynamic equilibrium. Okay, let's unpack that. If it's not a broken shelf, what is the better way for us to visualize this?
Think about the tripartite system that maintains pelvic stability. It's incredibly complex.
Tripartite meaning 3 parts.
Right. First, you have force coupling between the levator plate, which is the deep muscular floor of the pelvis, and the perineal body. Second, the posterior fornix of the vagina acts as a crucial biomechanical pivot point.
Okay, I'm following.
And third, you have coordinated neuromuscular regulation. Your muscles and nerves are constantly subconsciously adjusting tension based on whether you are walking, coughing, lifting a grocery bag, or just standing still.
I see. So instead of a wooden shelf, it's actually much more like a complex suspension bridge. You have all these interlocking tension cables, pivot points, and load-bearing structures that are designed to, like, sway and adjust to different weights dynamically.
That is a brilliant way to look at it. And if specific cables on that suspension bridge lose their coordination, maybe due to the immense physical trauma of childbirth, age-related changes in collagen, or a localized injury, it changes how the mechanical weight is distributed across the entire structure.
So the organs aren't just simply falling down because of gravity alone.
No, they are actually being pushed in abnormal directions by the body's own intra-abdominal pressure.
Oh, wow.
Every time you breathe or move, you generate downward pressure. When that dynamic equilibrium is disrupted, the force transmission vectors are completely altered. This leads to characteristic prolapse patterns based on which cables failed.
Can you give an example?
Sure. If the anterior wall loses support, the bladder bulges backward into the vaginal space, creating what's called a cystocele. If the posterior wall gives way, the rectum bulges forward, causing a rectocele.
And this causes a completely different set of symptoms compared to the microscopic nerve fire, right? We're talking about deep pelvic pressure, a literal feeling of a bulge, and functional issues like incomplete bowel evacuation because the mechanical plumbing is literally kinked.
Exactly. It's a
Right.
macroscopic shift in the tissue layout.
Okay, but a patient is sitting there in an exam room. They're in distress. They might be complaining of pain during intercourse, severe pelvic pressure, or burning. How is a clinician supposed to practically map a dynamic suspension bridge collapse versus a hyperactive microscopic nerve fire in a standard 15-minute appointment?
That is where the clinical toolkit comes in. Clinicians have developed highly specific, standardized physical exams to differentiate between the localized neuroinflammatory response and the pure mechanical tissue layout changes.
Okay, let's get into the toolkit.
Let's look at how they test the structural side first. To measure that suspension bridge collapse, they use a system called the POPQ.
Pelvic organ prolapse quantification.
Hmm.
Our sources go really deep into this, and honestly, it looks like a topographic map.
It essentially is a 3D topographic map. The POPQ system is designed to objectively measure anatomical descent. And to do that, you need a fixed reference point, a ground zero.
Right.
In this exam, the hymen is designated as point zero. Anything inside the body sitting above the hymen is measured in negative centimeters. Anything protruding outside the body, pushing past the hymen, is measured in positive centimeters.
So instead of a doctor just subjectively guessing, it looks like it dropped a bit, they are taking precise numerical coordinates of the anterior wall, the posterior wall, the cervix, and plotting exactly how far the structure has caved in relative to that 0 point.
Exactly. And crucially, based on our sources, this cannot just be done while the patient is lying completely relaxed on an exam table.
Right, because it's a dynamic equilibrium disorder. If you only look at the bridge when there are no cars on it, You won't see where it's failing.
Spot on. The POPQ measurements must be taken while the patient is actively straining, coughing, or even standing up.
Wow. Standing up during the exam?
Yeah, the clinician has to recreate the intra-abdominal pressure that the patient experiences in their daily life to see the maximum protrusion. Based on those precise grid numbers, the prolapse is staged from 0, meaning perfect support, all the way to 4, which is total aversion.
Okay, so the POPQ maps the macroscopic structure. It tells the doctor exactly what the mechanical tissue layout looks like.
Yeah.
But what about the microscopic fire? How do they test for the rogue security system, that neuroinflammatory allodynia, without doing a biopsy?
For that, they use pain mapping. Specifically, they utilize the VMP protocol and the Q-tip test.
VMP.
VMP is an acronym that stands for vulva, anus, pelvic muscles, and paraurethra. It's a systematic way to evaluate the sensitivity of both external and internal tissues.
Okay, we absolutely have to talk about the Q-tip test because I found this incredibly amusing in the research. We just talked about this highly complex 3D tomographic grid for measuring prolapse, and the tool they use to diagnose highly complex neuropathic allodynia is a literal cotton swab, the same thing you buy at the pharmacy.
It is entirely absurd when you think about it, but a standard Q-tip is actually a highly precise medical instrument in this context.
I mean, if it works, it works.
It's all about how it is used. The clinician takes the cotton swab and applies a very gentle, standardized pressure to specific sites around the vestibule, like the base of the hymen. But before they do this, they touch a neutral area of the body, like the inner thigh.
Oh, okay.
They ask the patient to establish that feeling as a 0 on a pain scale of 0 to 10.
So they set a baseline for what soft cotton feels like on normal nerves.
Exactly. Then they take that same cotton swab and touch the vestibular sites.
And because it's just a soft piece of cotton, the score should be 0. Or, maybe a 1 if the pressure is slightly awkward.
Right. But if the patient consistently reports a pain score of over 3 from that incredibly soft touch, it confirms the presence of allodynia.
Oh, wow.
It proves clinically that those nociceptors have proliferated and are misfiring. The brain is interpreting the light touch of a cotton swab as a painful burning or cutting sensation.
See, this is where the detective work gets incredibly intense for me. We've set this up as a differential diagnosis, right? The clinician is trying to figure out if it's A, the microscopic nerve fire, or B, the macroscopic structural collapse.
Yes, that's the standard approach.
But when I look at the 2015 consensus terminology and classification of persistent vulvar pain, there is a fascinating overlap. They actually list structural defects, like perineal descent, as a potential factor associated with vulvodynia.
This raises an important question, and that overlap is where the entire paradigm of pelvic health is currently shifting.
Because if a structural descent can be associated with the nerve pain, aren't these two distinct exams sometimes measuring two sides of the exact same coin?
How do you mean?
Well, think about the suspension bridge. If the physical floor drops mechanically and everything is sagging out of place, doesn't that structural tension physically stretch and anger the tissue? Does the macroscopic shift actually cause the microscopic fire?
You've just hit on one of the most critical questions in modern pelvic medicine. Historically, medicine loves to separate things into neat boxes. You go to a neurologist for nerve pain and a surgeon for a structural collapse.
Right, keep it simple.
But the human body doesn't respect those boundaries. Think about what happens when the pelvic floor loses its dynamic equilibrium. The tissues are subjected to abnormal stretch and shear forces every single time the patient stands or breathes.
And chronic mechanical strain is basically a form of localized trauma.
Exactly. And what does trauma do? It triggers an immune response.
Oh.
It is highly plausible that the constant mechanical stress of a mild prolapse is the exact mechanism signaling those mast cells to accumulate, release heparinase, and trigger the nerve proliferation.
So the suspension bridge cables are sagging, and that physical strain is what trips the rogue security system.
In many patients, yes, that is the working hypothesis. It perfectly explains a major clinical anomaly, why some women with a very mild stage 1 or stage 2 prolapse on a POPQ exam experience disproportionately severe pain that maps perfectly on a Q-tip test.
That makes so much sense.
The structural drop might not be severe enough to require reconstructive surgery purely from an engineering standpoint, but that constant mechanical tension has created a localized neuropathy.
That completely changes how you have to look at treatment, because if a doctor just gives a patient a topical cream to treat the microscopic inflammation, but their structural floor is still sagging and pulling on those tissues, the fire is just going to keep reigniting.
And conversely, if a surgeon only performs a structural repair, say, placing a mesh to fix the prolapse, but they don't address the fact that the nerves have already physically multiplied and embedded themselves near the surface.
The patient wakes up with perfect anatomy but still has the pain.
Exactly. They might have perfect anatomical support, but still suffer from severe, debilitating allodynia.
It really emphasizes why clinicians absolutely have to use both toolkits simultaneously. They need the POPQ to understand the load-bearing architecture and the Q-tip test to understand the neurological software running through it.
It's mandatory for comprehensive care.
And they have to weigh all of this against a patient's individual history. Like, did the pain start after childbirth, suggesting a biomechanical disruption? Did it follow a series of infections, suggesting an immune trigger?
Exactly. And this is exactly how they navigate the conflicting HPV data we discussed earlier.
Oh, right.
If a patient presents with severe allodynia and tests positive for HPV, the clinician doesn't just assume the virus is the cause, they use the POPQ.
I see.
If they find a significant structural collapse, they might conclude the HPV is just incidental carriage and the mechanical strain is the real trigger for the mast cells. It is a masterclass in critical thinking. You cannot just treat the symptom, you have to trace it back through multiple interlocking physiological systems.
Okay, let's summarize the incredible journey we've taken on this deep dive. We started by looking at how the medical understanding of pelvic distress has finally moved far beyond the dismissive, it's all in your head.
Thankfully.
We looked at the microscopic reality of provoked vulvodynia. We explored how mast cells release heparins, literally chewing through the basement membrane, allowing pain-sensing nerves to multiply and push to the surface, creating a rogue security system of allodynia.
We also explored how clinicians map this invisible pain using the VAMP protocol and the humble Q-tip, allowing them to quantify a misfiring nervous system by establishing a baseline for soft touch.
Then we zoomed out to the macroscopic level, completely redefining pelvic organ prolapse.
Yeah.
It's not a broken shelf. It is a dynamic equilibrium disorder of a complex suspension bridge.
Right.
We saw how clinicians measure this physical collapse using the highly specific 3D topographic POPQ grid system while the patient is actively straining.
And finally, we discussed the profound overlap between the two realities, how the mechanical strain from a structural defect can actually be the trigger for the immune response that leads to nerve proliferation.
It is truly a marvel of medical detective work.
Huh.
But before we wrap up, I want to leave you with a final provocative thought to mull over. Right now, medicine is exploring treatments like mast cell stabilizers, drugs like ketotifen to stop the microscopic breakdown of tissue at the cellular level.
Right.
Meanwhile, they treat prolapse with macroscopic biomechanical support like pessaries or reconstructive surgery. Two very different treatments for two seemingly different root causes.
Very different approaches.
But what happens when future imaging technology evolves? What if, one day, we can see the exact microscopic mechanical forces, the literal physical stretching of individual cells that trigger a mast cell to burst and release its chemicals?
That would change everything.
Could the line between a structural issue and a neurological issue eventually disappear entirely? We might just find that every physical shift in our tissue, no matter how small, is the silent trigger for a microscopic fire, proving once and for all that our architecture and our nervous system are not just connected, but are fundamentally one and the same.
A fascinating possibility to consider. It reminds us that there's always more to learn, and that looking through multiple lenses is the only way to truly understand the human body.
Thanks for joining us on this exploration. Keep asking questions, keep looking for the connections, and we'll see you on the next deep dive.